Here is a presentation of anatomy and pathology of the sacrum. History of the sacrum. The Latin name of sacrum means sacred bone. In early English times it was known as the holy bone, as it was thought the human soul lived in it. It was commonly used in pagan religious rituals, and it is the last bone to decay in the process of human decomposition. The sacrum is a triangular bone which forms the posterior wall of the pelvis and transmits the weight of the body. It is formed by the fusion of 5 sacral vertebrae, S1 through to S5. It articulates with L5 superiorly, the coccyx inferiorly, and the iliac bones laterally. This is the anatomy of the sacrum, with the anterior and posterior views. Please press the pause button to view this slide for a longer period. Here we have the articulating surfaces for the sacrum. We have the iliac bones, L5 facets and the L5 vertebral disc, and the coccyx. Sometimes the sacrum will have 6 or 4 vertebrae, and some may not unite, especially S1 and S2. The bone varies considerably in its curvature. The bone is also shorter and wider in the female, increasing the pelvic cavity size. We will now review the connective tissue of the sacrum. Here we have the anterior and posterior sacroiliac ligaments. These reinforce the sacroiliac joint. On the left of the slide is the anterior longitudinal ligament, the sacral part, which transverses the anterior portion of the whole spine. In the middle is the anterior and lateral sacrococcygeal ligament. The sacrospinal ligament on the right is also known as the anterior sacrosciatic ligament. This attaches to the ischial spine. On the back of the sacrum we have the interosseous sacroiliac ligaments. These help against the anterior motion of the sacrum. In the middle is the sacrotuberous ligament, also called the posterior sacrosciatic ligament. On the right is the interspinous ligaments. The uterosacral ligament on the left. The uterosacral ligaments rise from the lateral borders of the sacrum posteriorly and attach to the cervix and body of the uterus, providing support. Here we have some illustrations of the nerves of the sacrum with the actual bone of the sacrum being removed. We have coloured in purple the appropriate nerve with the number associated. From S1, S2, S3, S4, S5, the coccygeal and the sciatic nerve, the largest nerve in the body. We now review some of the muscles which attach to the sacrum. On the left is the medial intertransversare. This is a contributor to the lateral flexion of the spine. In the middle we find the lateral lumbar intertransversare. This is the lateral flexor of the spine. The multifidus on the right is the extender and rotator of the spine. In this slide we have longissimus thoracis. This does extension of the trunk and neck. In the middle we have pubococcygeus, which aids in the constriction of the anal sphincter. Iliocostalis laborum on the right is an extender and rotator of the whole spine. In the slide we have the piriformis on the right hand side of the body. This is an external rotator, extensor and abductor of the hip. On the left we have latissimus dorsi. This does adduction and internal rotation of the arm and aids in respiration. On the right hand side of the slide we have gluteus maximus attaching onto the border of the sacrum. This is an extensor and also an external rotator of the femur. Here we have the left-hand sided ischio-coccygeus. This supports the pelvic viscera and is an elevator of the pelvic floor. We shall now discuss the blood vessels of the sacrum. On the left we have the medial sacral artery. This arises from the posterior aorta just above the bifurcation. On the centre slide we have another view of this artery. On the right slide we have the lateral sacral artery. This arises from the iliac artery. Here are the sacral veins. On the slide on the left, in blue in the middle, we have the medial sacral vein. This drains to the left common iliac vein. The two slides on the right, coloured in pink, show the left and right sacral veins. These drain to their relevant internal iliac vein. We will now look at fractures of the sacrum. Fractures of the sacrum are common in pelvic ring injuries in 30 to 40% of cases. About 25% are associated with a neurologic injury. Mistreated fractures can result in lower extremity deficits, urinary dysfunction, rectal dysfunction and sexual dysfunction. Here we have the two classifications of sacral fractures, the Dennis classification and the Isler classification. The Dennis classification is the one which is far more commonly used. The Dennis classification comes in a Zone 1 type, Zone 2, with Zone 3 being spread apart into the longitudinal sections and transverse sectional fractures. Again, please press pause on your player if you wish to review these diagrams a little longer. Here we have an example of the Zone 1 Dennis classification. There's a neurological deficit, usually about less than 5%, can involve the L5 nerve root and usually can result in a foot drop of the patient. The slide on the right is the Zone 2 classification. This involves fractures tracking down through the foramina. There can be a neurological deficit up to 30%, can involve S1, S2 nerve roots, and is quite a difficult type of fracture to fix. Here we have the Zone 3 classification within the Dennis system. As you can see, it is split into two types, the longitudinal and also the transverse. In the longitudinal one, the fracture can involve the whole sacral canal. There can be a neurological deficit of 60 to 100%, can involve the chorda equina, and can result in the loss of bladder, bowel and sexual function. Here we have a lateral view of the Zone 3 transverse fracture type. This can lead to a canal compromise and is best detected on lateral views of the sacrum. In this slide we have 5 different types of repair of the actual sacrum fractures through different types of screwing and plating. Sacroplasty is similar to vertebroplasty, but the cement is injected into the sacrum and fracture site instead of a vertebral body. It can be performed on patients to improve its stability and to reduce pain. This is suitable on patients who are unsuitable for different types of actual mechanical repair through plating. We shall now review some sacral tumours. On this slide, in the top left hand corner, we have chondrosarcoma, bottom left hand corner, myeloma, on the right upper renal cell carcinoma metastases, and down the bottom we have Ewing sarcoma, which can be incredibly aggressive. Sacral chordoma. Chordoma is a bone cancer that belongs to the sarcoma family, and about 50% of these tumours occur in the sacrum. They are a slow-growing tumour and difficult to treat. Treatment is by surgery and follow-up radiation. there is unfortunately a high chance of reoccurrence of these tumours. Here we have 4 pictures showing the extent of invasion of chordoma and an actual surgical example. Congenital defects. Here we shall discuss spina bifida. This comes in 3 different types. Spina bifida occulta. This is Latin for hidden. The outer part of the vertebra is not closed and occurs in about 15% of people and is split so small that no spinal contents protrude. Meningocele number 2 is a defect where the meninges terminate but with no damage to any of the nerves. Number 3, the worst of the cases, is myelomeningocele. It is the most severe of these types, and the defect allows the meninges and nerve roots to protrude through the opening, while the physical effect is depending on the severity. Here we discuss the congenital defect of caudal regression syndrome. This is also known as sacral agenesis, where there is abnormal fetal development of the lower spine and occurs approximately in 1 in 25,000 births. It is an anomaly which is associated with maternal diabetes mellitus. Sacroiliitis. This is inflammation of one or both of the sacroiliac joints. It is caused by trauma, infection, or just osteoarthritis. Chronic sacroiliitis can cause fibrosis and calcification all around the joint, and this is treated by anti-inflammatory medications or steroid injection. We see here an MRI and an X-ray showing this particular condition. Thank you very much for watching this presentation of anatomy and pathology of the sacrum.